Okay, ladies and gentlemen, welcome to the Thoracic question and answer. It's up to you guys to ask questions, and my panel of experts, which is half the size it used to be, can answer them. So any burning topics that you want to bring up?
Yep.
Professor Gaines, wait for the mic so people can hear you.
It seems to be normally things that are conceptually mad don't work. Can you discuss whether we think chimney graphs are here to stay?
Who wants to take chimneys on? Crassy.
Why do you always pick up on me? You know, something with my name or what? No, thank you. As opposed to everybody else in this place. I don't understand that chimney. What's the problem with chimney? You know.
I can't understand conceptually how you ever think you're going to get a good seal.
All right. For me, chimney is not a. It's never been a question of seal. It's been question of patency of target vessel. All right. So if you cover unintentionally or intentionally, whatever target vessels there may be, from the rhinos, for example, both rhinos, and you have a very short neck that is definitely unsuitable for stent graft, infrarhinal stent graft. You have no fenestrations, no time, and then you're looking for a solution. One solution would be to have the graft placed intentionally partially covering the renal arteries, get the stents from above in the left to right renal, maintain patency, and don't worry about the seal because the seal is below the rhinos. So nothing to do with it.
I'm talking about people intentionally doing it.
Hang on, you need a mic because people can't hear at the back.
I'm talking about people intentionally doing it, planning it for both abdominals and thoracics.
But as you know, the number of chimneys are directly related to endoleaks. If you use one chimney in the renals, seems to work, as there is some sort of a neck under lower distal to the renals. You start to two chimneys, may or may not work. If you have three chimneys, they definitely not work. So back to the seal, it's not the seal, it's the patency. So if you look for patency and look for some sort of a shortcut not to use fenestrations, that's a bad idea, I would say.
So the point was made that balloon expandable stents could be crushed. Self-expanding stents as the chimney might not work long term. Do you believe that? You said you then put a balloon expandable in it.
But again, this is more like related to arch, subclavia, and left carotid, and it's a different area. And of course, if you place layer upon layer, the risk for crushing is less. That's self-explanatory. But whether this is going to replace branches, fenestrations, I doubt seriously. However, and there always however I've learned in this place, if you use the technique that the Brazilian guy is using, the sandwich technique, with the long chimneys that are sandwiched between two stent grafts, make sure the gutters are very narrow, and possibly that can work. Possibly, I would say.
So, that's for internal iliacs, isn't it, largely? And we've never done any chimneys. Well, because conceptually, and we're talking about thoracics, aren't we? We're largely talking about putting a stent graft in the left common carotid or the left subclavian. Conceptually, two circles don't necessarily make a seal, and conceptually, if you talk to the engineers, big stents crush little stents. So as a bailout technique, if you inadvertently cover something, I'm sure we'd all think that's reasonable, but electively, we have hybrid surgical options, don't we? So a carotid bypass or a carotid subclavian bypass is not a particularly morbid procedure in the majority of cases. And I suppose we've always taken the view that you can do the surgery and avoid an elective chimney. Having said that, the people who do a lot of them, like Mario Lachad has just presented his series in the main hall, are claiming very good results from it. And it may be that there are certain combinations of stents that do actually create a seal and do actually work together, and you can envisage that if you had something like that, you fortuitously stood there, where you're getting the seal with a polymer injected around a ring, you could actually see how with that particular graft a chimney could work, Pete, I think, because you put the chimney in place and then you fill the polymer around it. So that's been my take on it, that conceptually I don't necessarily like the idea. Where there's an alternative surgical option, I'll take it. But, I think you wait and see, don't you?
John, have you anything to say on chimneys?
Really not much to add. I think most of us started with a bailout when we covered something we didn't want to, the left common carotid or the celiac. And it's worked in a handful of times, but I have just as many handful of times where it hasn't. Oftentimes the stent wraps around your stent graft and it's not in the lumen at all, so you've created a type 1 endoleak. Sometimes I think the materials not only are crushed, but there's so much motion there, I can't believe that stent's going to last very long in the long term. So I'm not a big fan of chimneys. I think we do it because it's available, it's easier than doing a homemade fenestration, and for one branch, especially in an emergency, it can get you home. But I don't think it's not the long term. I think the in vivo fenestration or the branches are the future.
Santi, next.
My question regards the topic that Eric Verhoeven showed yesterday about the use of branched and fenestrated graft in chronic dissection, who to me looks something not so much reasonable. I would like to know what the panelists thinks about, if they have any experience.
Vincent, have you had any experience of branched and fenestrated for chronic dissection?
Not for chronic type B dissection for sure, just for thoracoabdominal aneurysm. But in some circumstances could be possible. You have enough room to deploy and to open your sleeves and play with the catheter to catheterize your side branches. The presentation was this morning. Was yesterday. It was this morning. As far as I remember, he suggests to put a pre-thoracic graft in order to open up a little bit more the false lumen. But it's a little bit difficult to predict how is the behavior, how will be the behavior of the new endograft inside of the narrow entourage. And for sure, you can get in troubles if the next thoracic endograft is enfolded inside the narrow through lumen, and then you have already ordered your branched endograft. Takes a lot of time. It takes a lot of money. So for this reason and other reasons for the type B dissection, chronic ones, when it becomes aneurysmatic, we move for a mentality right now to open surgery when it's possible, or do nothing is another alternative in some cases.
Krasi, you going to have a view on this?
I'll try to do something. I wouldn't say nothing. If the patient is a reasonable age, reasonable state of health, etc., that we'll do something. But of course, there is limitations to that. When it comes to the chronic type B dissection, thoracoabdominals, the issue there is the small true lumen and how to open up that. That was the question. To place a stent and hope for the best may or may not work. But if you use a fenestrated graft that is tapered to 18 millimeter, okay, that's probably the smallest possible that you can use. Then you can go in before starting catheterization using a balloon to open up, to just open the stent as much as possible and then fenestrate. That's one way of doing it. And I've done it just a few cases. Then the other way of doing it, if the false lumen is large, and I was showing that today, we've done it once. False lumen is large, and there is a landing zone on the top from a graft, for example, or stent graft. Then it's possible, fully possible, to go from through false lumen, then create fenestrations with a tips needle above the target vessels and use branches. The moment you use branches, you're dependent on room. One branch is 8 millimeter for celiac, 8 millimeter for SMA, 6 millimeter for renals. So then the stent graft, the main stent graft, can be reduced to 16 millimeter in diameter and it still works. So you have to have room for these branches. And if there is no room on the true lumen, you can place that in the false lumen and connect it through the homemade fenestration, just made them through the membrane using a snare and a false lumen, a tip needle and the true lumen, and then use these fenestrations for placing branches.
Matt, anything to say?
I suspect that, so I've not done any total endovascular solutions for chronic dissections. I suspect they're right at the far end of planning and technical complexity, and I think in our centre we've probably not done enough thoracoabdominal branches to go down that route. So as Ian presented this morning, our preferred approach for large thoracoabdominals from a chronic dissection is a hybrid, actually, because they've usually got good target vessels, they've usually not dissected too far down them, and the only pitfall, I think, is you have to make sure that the inflow is okay, which usually means you've got to stent the thoracic aorta beforehand. Ian, I don't know, do you want to say anything about it? Ian gave the results this morning of ours, and actually our results for chronic dissections using that technology are good. But actually for me, the endovascular technique with a really small true lumen is probably, we're probably not at that stage yet, to be honest. Pete's done some as well, I think.
You had a question.
I did. I wondered if we could go back to the arch. I'd be interested in what the panel feel is the main challenge in terms of design of an off-the-shelf branched arch device, because that would take out the need for chimneys and some of these other complex solutions. So what's the biggest challenge in terms of design, and do you think it'll ever be achievable to fit most arch disease?
Nice question.
So Crassy's going to talk to that one, I can tell.
Go ahead. No. Okay. I believe the most challenging point in the arch is the orientation, because arch is oriented in a multiplanar fashion, you know. And one solution is to perform some kind of funnel design in the side orifices to have enough room to allow some mistakes in the orientation, and go through the funnel and even maintain perfusion to the side orifices through these kind of funnels. And even you can play with antegrade flow through the branches. Another solution is for one single branchet is to go with the two wires from the groin. For instance, is like the Gore platform, but never reach the market at the moment. Is much more relaxing because you can cannulate before with side branch and the main through lumen or main endograph wire, and then over that, like a train over two wires, and accurate positioning of the side branchet and put an side endograph inside the subclavian artery or whatever. But for sure it's a very challenge. It's not so easy to have the answer. Even the relationship between the main body and the side branches due to the motion inside the thorax is a huge amount of stress. And from the mid-long term could be also another important issue.
Krassy?
Problems with the arch and stent grafts is orientation. That's the major problem. Not only that it's curved, but it's curved in a three-dimensional space. In addition to that, the supraortic vessels, they are oriented always off. You know, they don't follow the pattern. And the next then question you're having, how can you handle this unpredictable situation with off-the-shelf devices? My understanding of that is if you have a pre-curved cannula, like the same with Valent stent graft with this spine wire, the pre-curved wire always tends to orient itself in a curved aorta automatically. Yeah. So that can be taken as a way of orienting something. And then again, my understanding of that is if you make the branches being big on the outer curve, that facilitates again orientation automatically in outer curve, and only issue of catheterizing these big funnels is to place them more centrally to the supraortic vessels. So with that in mind, then you have a device that is tapered, that gives you a seal on the top where that needs to be. Then depends on quality of the ascending aorta, of course. Then tapers to whatever diameter that needs to be to allow for a space. Anytime you catheterize anything from inside out, from outside in, you need to have space. And if you create space, not by squeezing the graft only, as plenty of stent grafts are squeezed, but also create space by reducing the diameter of the stent graft, then your chances to hit this big funnel are pretty good. So to the question how hard it is to make branch stent grafts to fit any anatomy, maybe we're not that far off. But again.
Yeah, Matt.
So I won't talk about design of stent grafts because I think Krasi's probably leads in that field, but I do worry the tendency to go down the total endovascular route for the arch is leading us into problems with stroke. So if you look at all the aortic arch series, the biggest serious comorbidity and the biggest cause of death is stroke. And the further you go around the arch, the higher your stroke risk. And I suspect, although, I think we've got 30 totally stented aortic branch endografts in the world, so there's obviously not enough data, but I suspect the more branches you have and the more vessels you have to catheterize, the higher your stroke risk is going to go. And to my mind, that's the real crux of improving clinical results in the aortic arch is how we're going to reduce the stroke risk, because it's high, it's over 5%, it seems to get higher the further you go round. The aortic arch is often awful in its appearance, and I think probably we do need to pay some attention to perioperative medication, and I suspect we need to pay some attention to understanding the mechanism of stroke, whether filters are a way forward, but possibly it actually may be one of those aspects where a surgical debranching, other than the innominate, may well be safer than an endovascular solution in terms of cerebral embolization.
Yeah, John, you shared a great case this morning where you did a rescue of an occluded internal. I mean, to have that level of expertise available instantly in your hospital must be very, very rare.
No, we have it all the time. And
because you work with neurosurgeons, neuroradiologists?
I trained 2 neurosurgeons, and we have 2 neuroradiologists, but they're always available, and we work well together. It's really nice to follow 3 experts. I don't have a lot to add, but I would add what Krasi was saying about the 3-dimensional anatomy. So the Neutograph takes advantage of that 3-dimensional anatomy to design pre-curve. They have 19 shapes that will fit to line the fenestrations or scallops, they call them, up with a greater curve on the arch. And I do agree with Matt that stroke is going to be our major problem. There's detachable filters that people are using. Inouye, who had this 3-branch thing, I think reported a 25% stroke rate in his initial experience. So clearly stroke's something we have to address. And I think we also have to consider the open surgical option for ascending an arch. The cardiac surgeons are getting pretty good at this at my place with retrograde cerebral perfusion. They can fix the coronaries and the aortic valve at the same time, which we can't. And I think relative to a thoracoabdominal, the surgical approach has some is less morbid.
There are plenty of seats down the front if you want to come in, so you don't have to stand at the door. And there's one thing, this morning when you were talking about the Mercy retriever, which is a kind of corkscrew which you can remove the thrombus, you then said you needed help from your neurosurgeons. What was that about?
So what I do is I page them as soon as I have a case that I think might need them. And usually within 5 minutes they're there. That particular case, I put the times on. It was 5:30 p.m. Friday, and he wasn't there, so I just started doing the case. And it wasn't the internal. It was an embolus up to the M1. Okay. And so I repunctured my pre-close. I had the
So hang on. Just for the benefit of the audience, the M1 is a road which goes from here up the...
Yeah, okay.
Scotland.
It was the middle cerebral artery that had the embolus.
Thank you.
But by the time I had a balloon sheath in the carotid, he was there, and I'm perfectly happy to have him manipulate with the intracranial vessels. I think those are special skills which, if no one else is available, I might pass a microcatheter up there and put some TPA, but I would not feel comfortable with what they do every day in the intracranial circulation.
So there is another, there's a sort of suction balloon, isn't there, where you can milk the clot back into a sort of continuous...
It seems like every 3 months there's a new device they have available. And when you look at the selection of their microcatheters and wires, it's endless, and I think those skills are truly unique.
Cressy?
About medication.
Well, yeah, just a minute. I just want to finish with, so Cressy was talking about often patients stroking out and then you're doing a run and you don't find anything.
That happens, yeah. I've seen that, and I do admire, John, that what you're saying. Neuro interventional radiologists possess skills that are incredible in terms of retrieving emboli with Mercy, that's corkscrew and other devices. But when it happens and you don't see anything, no matter whether you're a neuroradiologist, interventional skill, but it's nothing. What do you do then?
So you can't do anything. What about just putting TPA blind? I mean, what are you treating? You don't know.
Of course, my limited experience on that, you put TPN blind and nothing happens again. So what do you do next?
If they're hemiparetic and aphasic, there'll be a problem with the internal or the middle cerebral, the striates. So I think what you're talking about, people who have a weakness of a hand or maybe a worsening lesion, I usually think of those like I do after carotid endarterectomy. There's probably some distal embolus. I'm going to scan them and make sure they don't have a bleed. Then I'm going to put them on heparin, maybe dextran.
Okay. Matt, you want to talk about medication?
Well, I did. So I was just interested in what people do. So,
well, we can liven this lot up and have a vote. Have you got a question for them?
Well, so the question is deriving from Pete's old data in the early stages of carotid stenting, the results, Pete, I think I'm right, got dramatically better when you added in dual antiplatelet agents. The biggest step change in carotid stenting, and at the moment we do our aortic arch procedures usually just on aspirin, don't we? And we're not giving them clopidogrel. So should you have all these guys on dual antiplatelet agents?
Ah, good question. Can we have a microphone to this? Wait, you can't hear you. Just be calm.
You're losing control.
No, I never lose control.
Oh, yeah.
Now.
And you could, most of these are electives, so you could dose them to hell with statins too, couldn't you? So you could wind up the statins and put them onto dual antiplatelets.
So basically that's what I'll take with me now from this great panel, that whenever we do arch device, then we'll have them on statins and dual antiplatelet.
Well, no, it's a question. So the answer is the question was should you, and does anyone do it?
But
so we don't.
Need some times to be active. See, how long before?
Sure. I think
1, 2 months? No evidence about that.
I would say the thing to take home is you should look, though. While you have a sheath in there, I think to do an ascending injection with a flat detector, you can get a pretty good cerebral angio and know whether there's some large vessel occlusion there before you wake up the patient.
Are you on the same subject?
Yeah, I'm afraid the stroke after carotid stenting is completely different from stroke from an arch embolism. I mean, dual antiplatelet can prevent thrombus formation at the level of a disrupted plaque at the time of carotid stenting, but a theratomatous plaque that embolizing to the brain, I don't think that a dual antiplatelet can do anything.
I do not agree completely. Say, when you place stent grafts that are so huge in terms of surface, and you can read that from all inflammatory parameters you see. They get the CRP, the platelets down, you can tell this is something foreign body. And that foreign body accumulates so much of whatever is there, platelets not the least, and the flow is so high, so it's enough to scrape it with one catheter, no matter how gentle you are to catheterize. That's the risk. Okay? So that's I would rather go with what
Are you on the same
Peter
subject?
says.
Completely different.
On the same subject. Yeah, we'll take this one first, Martin.
Well, my question is just following. If you're on aspirin, should you be on clopidogrel for weeks before, or is it enough to take one tablet like we do before carotid surgery,
we've now got the routine introduced by Ross Naylor and the Leicester Group that we always give 75 milligrams of clopidogrel the day before surgery. Is that enough, do you think?
No, I think you have to. I mean, I think if we haven't done it, but we're thinking about it, I think you have to load them with 300 the day before and then maintain them probably on 75 milligrams. But I'm not sure that the analogy to carotid stenting, Fabio, is completely wrong, because, you know, I do know carotid stenting, but I'm told a lot of the problems arise from difficult access and manipulations through the arch and through tortuous vessels, and that's not a disrupted aortic plaque. You know, that's stroke from manipulation within an atheromatous arch.
I was thinking about the dual antiplatelet that works probably after.
Well, I don't know.
Okay. Yeah. Another question here.
I have two questions related to performing open surgery in the setting of previous stenting. The first is, do any of the panel have experience of and any tips for how to remove stents? And the second is, do they have...
Shall we take that one? Because we've all got Alzheimer's up here. We've all got short-term memory loss. Tips for removing devices.
Do you mean TEVAR or carotid stents?
TEVAR.
Yeah.
TEVAR.
I have a little bit of experience.
They're all your own, right?
If you once thought that chronic dissection was useful, you know, now you have the stent graft and the aorta is big. So I think there's, you know, you have to know which device it is. And if it's self-expanding, you can put a Crawford or Fogarty clamp over any of them. And then when you're sewing to the stent graft, the suture retention capabilities of the polyester or PTFE are usually not the same as the surgical equivalent. So I'll put a felt ring around the endograft, and I'll suture the native tissue as well to it. So that's how I do my anastomosis. And it's always a problem when you start cutting that metal, because now you got all these sharp things in there. When in removing them, people talk about the same with EVAR grafts, cooling down nitinol, twisting, constraining it radially. Use any technique you can, but you always risk disrupting that native aorta when you take it out. So if I can, I leave the stent graft in place.
Yeah, that's very sensible. And the worst one by far is the Cook, because his spikes are so long. Have you any experience? Nothing ever goes wrong in Barcelona.
I don't have personal experience, but my cardiothoracic surgeons in my department has experience. But it's exactly that Matsamura told, cooling a little bit is very easy to retrieve, except probably the Cook device.
Your second question?
Answered it, really. It was the anastomosis to the stent graft.
Yeah, okay. We have another question over here? Yeah.
Just following on from that talk about dual antiplatelets, would that then make it difficult to put spinal drain in?
That's a very good point. So we do most of our procedures under an epidural, and the anaesthetist refused to have anybody on clopidogrel. So it would alter the way that we work.
The anesthesiologist guidelines say it's not it's not recommended to use a spinal puncture for even for local regional anesthesia under clopidogrel, unless the clopidogrel is removed 5 days before. Because they collect some kind of bleeding issues for this particular.
Santi, have you got a...
Is related to medicaments as well. If the panelists manage these patients after TEVAR with some particular type of antihypertensive medicaments, or if this patient continue to have the same pre-TEVAR medical management. I mean, do you change, or you are thinking to change the medical therapy post-TEVAR procedure?
So what is your point? What are you getting at?
Yeah, there are some papers. There's a report about some news with use of RIBs when patients have ascending disease as well. There are still unpublished papers that say that we observed in the registry, in the IRL registry, that calcium channel blockers may help in aortic remodeling in the descending aorta in the chronic post-dissection time. This is completely news, but there are some papers from John Hopkins that say something about thoracic aorta.
Well, so there's a couple of things here. I mean, I think if you've got a thoracic endografting program, I think you do need to have a protocol about your antihypertensives. So I know that's not directly answering your question, but I think it's an important subject. And I think you do have to think about what you're going to do with patients' antihypertensive medication if you're putting a long segment thoracic endograft in view of mitigating the paraplegia risk. So in our unit, we stop the antihypertensives the day before surgery and don't restart them until the patient is ready to go home, essentially. So we're keen to run a relatively high blood pressure after most thoracic endovascular procedures, and I suspect that's our policy because we are very selective with our spinal drains.
You want to come in, Vincent?
Just to emphasize the last point from Matt, be careful about the hypertension thing, so hypertension events post-TIVA, because you can...
I want to stop you because my question was related to the long-term follow-up of this patient.
For the long-term could be...
If you change the medical management in the long-term follow-up, I'm sorry, I didn't complete
it could be, but it's much more important to avoid paraplegia, delayed paraplegia, even when the patient is at home and coming back with full paraplegia due to the hypotensive drugs are taken as a regular regimen before.
Doesn't it also depend what pathology you've got? So if you're dealing with dissection, you might want to put them on beta blockers. If you have aneurysms, that might not be quite that important. And then there's the sort of effect of losartan on patients with connective tissue disease. So there's all sorts of unknowns.
Like the role of the statins that now is coming up also in the aortic disease. That's it's a kind of a general medical management in post-TIVA.
I'm aware of that IRAD data. I think I was talking to Christoph about it, and he was saying to me that the association's there, but it's not particularly compelling at the moment, so that you would definitely change. But, I mean, you know the data better than us.
Okay.
Okay, so...
No, Matt, I agree with you, but there are some rumors that come from not from the registry, but from the companies that manage, from John Hopkins paper, from the Gentac registry. They are trying to say something more about medical management in thoracic aortic disease. That TIVA, that's what.
I think we probably all agree that vascular surgeons are not the people to treat blood pressure in these patients.
Will be vascular.
Okay, so I'd just like to, somebody approached me in the hall and said they had a patient who was unfit for surgery who had a mycotic thoracic aneurysm with Staph aureus, and they'd referred it to their tertiary endovascular center who turned it down flat. So they were asking my opinion. Oh, so I will ask your opinion. John, do you want to start?
Well, there's a couple papers that are published that claim you can put a patient, a stent graft in, and even for aortobronchial fistula, put them on antibiotics for a short period of time and they have a long durability. And I have not had that experience at all, nor do anybody I know has that experience. I think possibly they didn't have aortobronchial fistula, but possibly they just had a lung stretched over an aneurysm and got a little hemoptysis from that. So I think that TVAR for those infections is a bridge. If you think that the patient will somehow improve in 2 months and then be a candidate for surgery, it might work, but I think it's just a bridge. Sometimes a bridge for compassionate care is worthwhile too, though. Infected graft reminds me, you said zeniths are hard to take out, but I've taken out 3, unfortunately, and we take a bulb syringe and you can cut it to a taper, and then you don't risk your finger. You stick the end of the graft in there, and then you stick the bulb syringe up and twist, and it'll disengage the barbs. And you want to get all the graft out when it's infected, so that's a nice little trick.
Yeah, very good. Any more to say?
I would return a question to you, Peter, because you're the greatest man of infected grafts. And tell us now about your experience. We have only few of these. I've seen it. Yeah, it works sometimes, sometimes not. Especially when it comes to bronchial, aortobronchial, aortoesophageal fistula, definitely won't work. But when it comes to mycotic, it works. But tell us now what you know about that.
Well,
World's largest
interestingly, our first patient who arrived with massive hematemesis and had an aortoesophageal fistula. We banged a stent in, kept them on antibiotics, and they lived another 4 years before they got into trouble. We had discussions with our microbiologists about antibiotics, and they said, well, actually, you can never sterilize the esophagus, so don't worry
Which
about
can
it.
you predict? Can you tell which one are going to go well, which one are not?
But I think actually what the point, I think if you've got a fistula, patients don't do well, which is the point that you were making. And certain patients with aortoesophageal fistulae just go straight down the tubes whether you put a stent in or not. I've got a fabulous picture of an endoscopy with a hole through looking at some fabric, and that patient didn't live very long. But sometimes if they're not ruptured, then you can give them antibiotics and sterilize the sac. So this particular patient, the inflammatory markers have come right the way down, and then I think you can put a stent in. As you say, it's the only thing that you can do, and then I would keep them on antibiotics forever. But actually patients often decide when they're going to stop their antibiotics. Martin, you're going to say?
Comment on the same issue, because as you know, Peter, we also have an experience in these patients. We did 14 patients with mycotic aneurysm, and strangely enough, they do quite well. And you think of it as a bridge to open surgery, but in the end, either they do so well that you don't really consider open surgery, or they are so sick from comorbidities, because these patients often have multiple comorbidities, and they are on immunosuppression therapy, etc. So you don't really consider them for open thoracic surgery. And in the end, most of them do well anyway. So I think we were equally surprised, but it's worth a try in those demanding cases.
So that's the interesting thing about the bridge and dealing with it when the patient is well, to actually put them through what is actually a big operation. And I think the Roberto Chiesa would say that you have to do something to close the hole, either a mental flap or intercostal patch, do something to try and cover the hole. Otherwise, you're not going to succeed in doing anything.
I think summarizing that is, it's possible to treat endovascularly mycotic aneurysm, aortic bronchial fistula. Sometimes it's not a real orthobronchial fistula, some kind of inflammatory reaction or alveolar inflammatory reaction, making some kind of hemoptysis. But for esophagus, when the esophagus is involved on that, the panorama is, the scenario is very, very tough. So you can apply two prostheses, one in esophageal, another in the aorta, but you need to perform something else, otherwise the outcome could be catastrophic.
Very good. Any other questions from the floor? Oh, loads. Yes. Shall we take one here and then one over there? Yeah.
It's wonderful seeing a panel of experts, and Matt's whetted my appetite, if I may call you Matt. I'm not a vascular...
You can be as polite or as indelicate as you like.
We'll be delicate. We'll be delicate. We're wrestling with paraplegia, something that's flirted around in this meeting, but nobody seems to be tackling it. They seem to be obsessed, if you don't mind me reflecting, on death. And I would suggest that paraplegia perhaps ranks somewhat more superior than death. You mentioned that you were selective about your CSF drains, and some guidance as I try and understand why with closed techniques you get such apparently low paraplegia rates, and with open techniques we suffer, or they do, our patients suffer.
Paraplegia.
Yeah, it's the terrible conundrum, isn't it, of thoracic surgery. Patients hate you more if they've got paraplegia than anything else. I think there's no consensus amongst the endovascular literature about paraplegia. I think the things that we know for sure are that the longer the length of aorta you cover, the higher your paraplegia risk. I think we know that in the main, thoracic aneurysms have a higher paraplegia rate than dissections. And I think there's absolute evidence now that the collateral supply to the spinal cord through the left subclavian artery and the internal iliacs is of paramount importance. So I think they're the things we know, and therefore if you have a patient who requires a long thoracic coverage, it's imperative you keep their left subclavian artery and their internal iliacs. The issue about the spinal drain, I think each centre finds their own way. Our experience has been that we get almost as many problems with routine use of spinal drains as we got with paraplegia, and therefore we take the approach that we do the procedure, we're rigorous in maintaining collateral flow, we stop their antihypertensives, we run them at a high mean arterial pressure, and they are awake at the end of the operation, and if they have any spinal cord issues, we then selectively put a drain in. I'm sure other people have.
Is this working?
I'm sure other people have different protocols.
No, sure. But just pursuing the sort of the holy grail of no paraplegia, the Belgians, I'm flying a kite here, hoping they're not present, but I believe the Belgians really are pushing evoked responses and to assess when you get your problem within your spine. What role evoked responses, and should we as folk fiddling around with the thoracic, descending thoracic aorta, get into evoked responses?
Well, Mike Jacobs' data from Amsterdam, then Maastricht, on motor evoked potentials and open surgery, I think is second to none. But he's using that to guide him to say which intercostal am I going to put in and where do I need to search for intercostals. I think you're right in saying the rate of paraplegia in most series for endovascular is lower than open, but I'm not aware that anyone has actually proven the use of evoked potentials yet. I suspect you would have to use it to drive up your mean arterial pressure and perhaps lower your CSF pressure, but I have no experience.
Vincent, do you want to come in?
Yes, for sure. There are some recommendations coming from the American Heart with the STC societies altogether published in Circulation last year, September last year. And the recommendation is class 1 recommendation. And level of evidence is B, that means for a single center randomized trial or single center evidence on a big multi-analysis and studies that recommends spinal cord fluid drainage for specific high-risk patients. That means thoracoabdominals for sure, and very long coverage of the semithoracic aorta. For sure, there are some kind of complications regarding this particular method. That most of them are related to the bleeding issues, sometimes lethal issues. For these specific circumstances, yesterday I presented an automatic machine specifically designed in order to avoid these kind of problems.
Yeah, but as part of that series, you had a death, didn't you, directly related to...
But the death, it was before applying this particular device.
So as long as you had your automated machine, you'd be fine.
No, the death we had was a massive bleeding in the brain, and the second one was a spinal bleeding, was recovered by laminectomy, but both of them appeared before the automatic machine was applied. These two cases induced us to investigate what is happened with the neurosurgeons when you have to monitorize the peak pressure.
We have another question?
Yes, when trying to avoid this spinal ischemia, we drain the CFS and then we treat them vigorously with antihypertensives until we put the graft there, which we also do when we do hybrid surgery. Sometimes when we cease treating them with antihypertensive treatment, they go into severe cardiac failure. It's happened several times in this series. Is this something that you come across too?
Are you using the wrong sort of drugs? Is that the problem?
One may wonder. But even if it's not AC inhibitors, I mean, you try to do what you can to promote collateral flow. And one of the things there is to give hydration. The other is to cease antihypertensive treatment. Now, one other reason for this may also be, as we have speculated, that we are taking away a situation where you have a huge aorta and replacing it with only a straight tube, which will make it troublesome for the heart. And those two things together may force the patient into bi-chamber cardiac insufficiency sometimes even.
John, you want to take that?
Well, I talked about our routine. It also includes Narcan, naloxone low dose. We avoid nitride. We avoid rewarming. Our surgeons and our cardiovascular anesthesiologists feel very strongly that passive hypothermia is okay too, and the rewarming will create a sump effect. But as I mentioned when I was speaking, I tried to get 10 experts together to talk about motor evoked potentials and spinal drains and revascularization, and there's no agreement. And on no matter do people feel strongly that they're right at what they're doing at their center. So I think go to somebody you trust, see what their routine is. I think clearly has been espoused by Vincent, you have to have a system if you're going to do spinal drains, though. There has to be a team, somebody in charge all the time with the knowledge of how they fail and how they work, who's managing them, overseeing the nurses, and that helps greatly to avoid these complications from spinal drainage, which are very considerable.
Cressy?
To me, all of that makes sense in terms of protocol, team, when to place, how to handle that drain, the amount of cerebrospinal fluid that is drained, not to cause hemorrhages, etc. I personally believe that if you continue to perfuse the aneurysm with the perfusion branches, that helps to keep intercostals going until the patient becomes a circulatory stable. And we've tried that in the pain patients I was reporting on, and it seems to work. Now, how to handle that in terms of when to close these perfusions, fenestrations, branches, that's a different question. But that is being in a way supported by a cardiothoracic surgeon that done staged operation for occluding the intercostals. And that's probably another way of maintaining the collaterals to the spinal cord.
It's really counterintuitive, isn't it? We spend our whole of our first 10, 15 years trying to stop endoleaks, and then someone like you comes up and puts not one but two holes in the stent and says it's a good thing to prevent paraplegia.
But who says that you need to exclude the aneurysm when the pressure is down to 70? Who says so? You know that very well, that if you have a hypotension, especially when you operate for 6 hours and you're bleeding and all that, then that's the risk.
Yes. Oh, yes, a question at the back. Sorry.
It's actually just an extrapolation of the previous question. Most of the series that talk about aortic trauma, the incidence of paraplegia is quite low. But if you look at the anatomy of the injury, it's very often an isthmic injury. So your coverage is going to involve most often covering the left subclavian. What does the panel think about a prophylactic carotid subclavian bypass in an emergent situation?
Yeah. So most of these patients are stable, and that's why they lived long enough to get to hospital. So you've actually got plenty of time to do a carotid subclavian bypass if you want. But I can just tell you a horror story about a preoperative. So just coming back to your question, someone like Mac Macaroon, Pittsburgh, says that you never need to cover the left subclavian. In our experience, we have to occasionally. And we had a patient we did a carotid subclavian bypass on, uneventful stent graft. Patient went home and came back with a stroke in the posterior circulation, and we think it was caused by competitive flow between not completely closing the left subclavian and not plugging it, and then clot built up. For whatever reason, the graft went, and then this antegrade flow took whatever clot there was in the origin of the left subclavian up to the brain. That patient was fully anticoagulated by the neurologist without telling us and made a full recovery, and all the clot disappeared, and then we plugged the origin. But it was a scary moment in time because he'd done so well. But any more views on the panel? Cressy, you're leaning forwards? Keen, enthusiastic?
I would rather ask Matt to go ahead because he has such experience with the carotid subclavian bypass.
So the situation you describe is one where I think you can make a very reasonable argument for not doing a bypass. So one, it's an emergent operation, and two, in my view, in those patients, you should probably put in the shortest thoracic stent graft you have, because all you're trying to do is protect that bit of the aorta before it remodels spontaneously, which it will do. And actually, the risk of paraplegia for a 10 or 12 centimetre thoracic endograft is really quite low. So, I think that is a reasonable option not to do a carotid subclavian. Yeah. The thing against that is if you're trying to get these people back to normal life, they're often young and they often have arm claudication, but you can do it later if you want.
So I believe in the transections that we've dealt with, they're always stable and you've always got time, and we don't even do them in the middle of the night, you do them the next day. The difficult ones are the patients who are bleeding out, who are ruptured, who are no blood pressure, that you have to put the stent in. And we've had 2 patients who had disasters, one a posterior circulation stroke and one had a lemograph that we didn't know about. You usually find out though.
Can I follow that up with a horror story?
Yes, we've got plenty of time for horror.
Well, basically, the reason for asking that question was we had a 75-year-old fit chap who presented with just such an injury, and it was what would be described as a type 4 from the earlier talk this morning, where you had extraluminal dye contrast. So we took him to theatre and covered it with a 12-centimeter graft. We sort of patted ourselves on the back that he'd made a very good recovery, and he was transferred to the ward. And 8 hours later, he developed a dense paraplegia, from which, despite institution of spinal fluid drainage, he did not make a recovery. Upon completion angiography, there was retrograde filling of the subclavian. So that was one of the reasons why, although we debated a carotid subclavian bypass, we felt that perhaps he didn't need one. So I'd invite
So after when he became densely paraplegic, you put in your CSF drain.
We did, yes.
And then did you up the systemic pressure?
Yes, we tried to keep the mean arterial pressure above
and then would that
85.
then be the time to do the carotid subclavian?
Well, that's the question I'd like to ask. I mean, should that have been done?
That's what I think we would all suggest you should do.
Right.
Wow, we've done something useful. Okay. There was another question, yeah. Oh, 2 more questions.
Yeah.
You've got 5 minutes, guys, so let's make them snappy.
Very quick. The HIV is becoming increasing now, and we had a couple of thoracic aortic catastrophe from HIV. The patient was normal, had been investigated previously for whatever, and then been seen by the virologist, and they put him on the retroviral treatment. And within less than 2 weeks, he perforated his thoracic aorta. And we didn't know why. We put the stent in, and then we started looking around, and there's a few reports about perforation of the thoracic aorta when you start a retroviral treatment for HIV if the count is high. So we asked the virologist, don't do that. He insisted and gave him a double dose. He perforated again in another place.
So Matt is the only person I know who's dealt with an HIV thoracic aneurysm.
Yeah, we got a couple who've HIV who presented with aneurysms as a feature of the disease. I've not heard that story. I mean, my only our advice when we were dealing with these patients is to actually aggressively treat them to make sure their viral titer is virtually undetectable before you put the stent graft in. I've not heard of your story though.
Cressy, anything?
I have no experience from that.
Oh, okay. So we're not very helpful on that one.
Too young to.
We were brilliantly helpful on the previous one, but not on this one. Martin, last question.
Yeah. We were inspired by you, Cressy, because we had a few cases, I think only 2, where we covered the entire thoracic aorta, and they had previous infrarenal aortic surgery, so they were at high risk of paraplegia. And then we left a guide wire between the stent graft and the wall, so that we could possibly afterwards go in and put a Viabahn and reperfuse the aneurysm. In those 2 cases, we didn't need to do that because they didn't develop paraplegia. But my question is there any experience of such a routine? Because is it...
You're going to
how
use
much
a long
time
chimney.
do you have?
Yeah.
How much? Yeah.
Back to chimneys.
Well, that's because it's more practical just to leave the guide wire.
It's a good idea. Yeah, no, it's a good idea. And how long do you leave the guide wire in for?
To the next day. So
Okay.
for
Yeah, but
24
at least
hours.
it's a good idea.
With a sheath?
Yeah, with a small sheath.
And then the leg thromboses?
Well, there was no such, but of course that's a risk.
No, but the whole idea of perfusing the aneurysm, no matter how counterintuitive to you, Peter, it started with the case that Tim Shooter has described, and basically was a patient, thoracoabdominal, that everything worked out very well, and the day after, 2 days, she developed paraplegia, and upon which he placed a cuff, a chimney, a long chimney, snorkel, alongside the graft, and she recovered. And then he went in and squashed that with a giant Palmer stent. So back again to how critical it is to maintain the collateral circulation of the spinal cord, I believe it's very critical.
I think on that note, I'd like to thank the panel very much and for your participation. It was a very good session. Thank you so much.
Thanks.